All right, and then I will just start.
Okay, that sounds good.
Hi, I'm Duncan, a pharmacist here to discuss patient Kareem Schroeder in room 219. I was asked to assist in the pain management for his postoperative pain. We are addressing the switch to oral pain management to prepare for discharge in the next 2 days. Some background is that Kareem is a 59-year-old male who presents to the ED or who presented to the ED 72 hours ago after suffering a motorcycle accident. Orthopedics recommended an open reduction internal fixation of the left knee, and the patient has significant abrasions on all four extremities and a fresh incision without purulence or erythema on his left knee. All his labs are within range except his hematocrit, that's a little low, and his hemoglobin, which was also a little low. And then the patient's blood pressure is also a little high, but not a huge concern right now. All his other vitals are normal, nothing too concerning on the physical exam, other than the abrasions and then some nausea, vomiting, and diarrhea. No cardiovascular irregularities noted on the physical exam. And then the last progress note at 7:30 this morning shows that his diet has advanced and nausea has improved. And the patient is currently on acetaminophen, 650 milligrams every 6 hours for mild pain, morphine 2 milligram IV every 4 hours as needed for moderate pain, and morphine 4 milligram IV every 4 hours for severe pain. He has had a total of 1,300 milligrams of acetaminophen in the last 24 hours and a total of 22 milligrams of IV morphine in the last 24 hours. And he currently reports a pain score of 6 to 8 at rest and 9 when working with physical therapy. The resolution of the nausea and the improved diet are a good reason for switching the patient to an oral regimen at this time. And based on the last 24 hours, the patient is using 55 MMEs per day of IV morphine. And when adjusted by 25 to 50% for cross tolerance, a range of 28 to 41 MMEs per day should be used. The acetaminophen should be continued also, so a medication containing both would be useful. The hydrocodone and oxycodone are the formulations, or both have formulations with the acetaminophen already in them. The dosing of the hydrocodone allows us to get closer to that 50% reduction, whereas the oxycodone didn't really give us that. So we're going to use the hydrocodone. Since his pain score is 6 to 8 at rest and 9 when moving, I would also like to add an NSAID for multimodal therapy. Ibuprofen is fairly safe and effective and has been well studied, so we'll just use that one. And then as for my recommendation, I recommend starting hydrocodone and acetaminophen 5 milligram per 325 milligram tablets once every 4 to 6 hours as needed for pain for a duration of 5 days. I'm also going to recommend adding an over-the-counter ibuprofen 200 milligram, taking 1 to 2 tablets every 4 to 6 hours as needed for breakthrough pain upon discontinuation. And when the hydrocodone is discontinued, I would also recommend following up with the patient within an hour from starting the hydrocodone to assess for cross tolerance and to check vitals. I would also recommend following up daily while in the hospital to assess pain relief, respiratory and mental status, blood pressure, and bowel function. And then I would also recommend following up in 5 days to assess the need for further pain management or medication tolerance. That's my recommendation for switching this patient to oral pain management. Do you have any questions or concerns?
Um, so you're gonna do the hydrocodone, the ibuprofen. Were those the only two things that you recommended?
Yeah, the hydrocodone 5 per 325 with the Tylenol in it, and then the ibuprofen.
Okay. Any non-pharmacological treatments that you're gonna recommend?
Um, Ice and heat and rest, elevating the leg when not walking around.
Okay, perfect. And then and I think I just didn't catch this. When were you gonna have follow-up?
So follow up in 1 hour.
Okay.
someone should check on him in 1 hour and then just daily while he's still in the hospital. And then after he's discharged, follow up with a primary care provider in 5 days to see if he needs further pain management or if he can handle just the ibuprofen from there.
Okay, perfect. I agree with that. Let's see, how come you didn't recommend, how come you didn't recommend another opioid? Just out of
Um,
curiosity, like why not tramadol?
well, I didn't use tramadol just because tramadol has a lot of other pathways that it works on, and it's not just the opioid um, receptors that it works on. So it can have different adverse reactions, but I specifically chose hydrocodone just because the dosing fit within the dosing range of 28 to 41 with the regular tablet strength that
Perfect.
like the 5 per 325 is pretty common.
Okay. Are we worried about bleeding with the ibuprofen?
I would think bleeding is definitely something we should watch out for.
Okay, perfect. Okay, I don't think I have any other questions.
Okay.
Awesome. Um, okay, so you can stop your recording.
Um, there's stop.